So it's my pleasure now to introduce Dr. Neepa Patel, who is in the Parkinson's Disease and Movement Disorder Program at Henry Ford Hospital. She works both downtown and in West Bloomfield, the West Bloomfield location. Dr. Patel has been very kind in donating her time to give numerous talks for the Parkinson's Foundation, and we very much appreciate that. She's board certified in neurology, went to medical school at Wayne State University, where she graduated in 2007, and has done residencies and internships at Boston University Medical Center, both in internal medicine, neurology, and fellowship training, and received her fellowship in movement disorders working with Dr. Joseph Jankovic at Baylor College in Houston, Dr. Jankovic being one of the best-known experts in movement disorders in the world. So Dr. Patel is here today to tell us about non-motor symptoms of Parkinson's disease, and we very much appreciate her coming.
So when I was asked to speak about non-motor symptoms of Parkinson's, Mary Sue actually gave me a very long list of topics to cover. And I tried to organize them in a way that kind of made sense with just different body systems and body functions. So I'm going to try to explain kind of the medicine of about why some of these symptoms come up. So we'll go through just a very brief introduction to Parkinson's disease that I think will be relevant to understanding some of the non-motor symptoms. And then we'll just kind of delve into each topic. So a common story that I hear from my patients is that, you know, doc, I have seen 3-4 different doctors about a variety of complaints. I had a pain here, I have constipation, I'm starting to just notice that I don't feel right. And you go see one specialist, and then you go see another specialist, and then you go see a third specialist. And finally, after a few months to a few years, somebody takes a step back and says, wait, I think there's something bigger going on. Maybe you have Parkinson's disease. And so I really like this pictorial depiction of sometimes how a Parkinson's patient feels in the beginning, which is one person is just looking at one area and another person's looking at another. And it takes some time before the motor symptoms of Parkinson's present themselves in that classic depiction of somebody who is kind of slow and stiff and expressionless. And as many of you here in the room who have Parkinson's or know someone that has Parkinson's, this picture is a little out of date, but it still is a representation of kind of that classic motor phenotype of Parkinson's, of resting tremor, stiffness, slowness, and coordination and balance, and a variety of other motor symptoms. So when we talk about Parkinson's, and I know Dr. Wyant spent a lot of time talking about how we diagnose Parkinson's and just giving us a background, we really like to split up the symptoms into motor, which is visible symptoms to many other people, but also those symptoms that affect your movement and coordination. And then non-motor, those are the symptoms that other people can't see, but you experience them on the inside. And these can be a lot more challenging for people to understand and grasp. This list is not comprehensive, but it's a slide that I used when I teach other physicians just to highlight where some of the abnormalities are. Now, the list of non-motor symptoms is exponential. And Mary Sue had tasked me with a certain portion, and then Dr. George will be talking about a variety of other symptoms later on today in his talk on advanced Parkinson's disease. So just for a little bit of repetition, Parkinson's is a condition where dopamine is not being produced well. And they say by the time you start noticing your first symptoms that kind of makes the diagnosis of Parkinson's apparent, you have lost about 80% of the total brain dopamine concentrations. That translates to about 60% loss in the production capacity. And so what is neurotransmission and why is dopamine so important? Well, neurotransmitters such as dopamine help one neuron connect to another. And it's kind of that communication system. And when we have a reduction in that chemical compound, you have a reduction in that communication, which leads to reduction in movements and variety of other symptoms. And we're going to talk about neurotransmission as it relates to some of these other non-motor symptoms. The other thing I just wanted to highlight is, even though we spend most of our time talking about how the basal ganglia, the kind of a pocket of a few nuclei that talk to each other to help us move and function well, they also are involved in other areas as well, such as limbic system is kind of your mood, your psychiatric system. Associative is more of your cognition and thinking. Sensory is pain perception and just kind of overall perception, like smell and taste and various other things. And then finally, the motor. There are even more we're learning circuits, so it even affects your eye, controls your eye movements and a variety of other symptomatology. And the other thing I wanted to point out is that dopamine not only talks to the basal ganglia, but it also talks to other areas in the brain, and so it controls more than just movement. And that's why some of these non-motor symptoms present themselves. So without further ado, we will talk about the neuropsychiatric manifestations of Parkinson's. Now, there are more than what I'm going to be talking about here in this presentation, but as I mentioned, Dr. George will be addressing some of the non-motor symptoms that affect more advanced Parkinson's disease. So depression. This is a really common symptom in Parkinson's disease. Some surveys have said about 40 to 50% of patients may experience depression at some point. Now, there's a variety of reasons this may occur, and I know depression has this terrible stigma of just, oh, I'm down, I'm blue, and, all of us in society kind of say, well, pick yourself up by your bootstraps. And I wanted to explain kind of the science behind why depression may occur. Dopamine is a happy chemical. So when there's low states of dopamine in your brain, the reward and the pleasure is not as intense or even kind of close to normal. So it's very common for these patients, for Parkinson's patients, to experience depression. Now, most of Parkinson's patients have a mild sense of depression, a little bit of loss of interest, a little bit loss of energy and motivation, and that comes from also having Parkinson's. It's harder to move. It's a visible symptom, so it can be embarrassing at times. But for some people, this can be really incapacitating, or what we call major depression. You're unable to get out of your house. You're unable to participate with other people and enjoy and take pleasure and joy in, being out in the world and with other people. Now, for some people, this depression may come on several times during the day and seems almost random. And I've noticed, just by kind of pinpointing how people feel on their medication. Everybody here in the audience know what being on medication is? When the levodopa or your dopaminergic medicines are kicked in and working at their best, you're moving at your best. A lot of people feel like they have more energy and they're not depressed. And then as their meds are wearing off, they feel a sense of doom and gloom and sadness and lack of energy. Well, this can actually be fixed by just readjusting or recalibrating your medications. Keeping the on time on longer can help your mood. But for other people, it's just kind of a pervasive background symptom. And that may need other therapies. And so some strategies are obviously improving your overall dopaminergic regimen, or adding in a low dose of a mood medication such as an SSRI or an SNRI. Now, the mood medications have this label of being called antidepressants. And in a few slides, I'll talk about why I think antidepressants have a role in Parkinson's disease, even though you may not have that clinical depression that they show on TV. And there's a variety of non-pharmacologic, so non-medication therapies as well. So anxiety and depression, in my mind, kind of go hand in hand. And anxiety, I actually think, is more common in Parkinson's disease than actually depression. And there's a few reasons this may come up. So one is, if you are depressed, your likelihood of having some anxiety is higher. But also, it is another wearing off phenomenon. Sometimes your heart will start racing and you'll feel jittery and restless. And this is actually a symptomatology of Parkinson's disease itself. And so you're just starting to notice some Parkinson's symptoms creep back, and it translates into anxiety. So akathisia is that kind of restlessness. Dysautonomia is that irregular heart rate response to coming off of your medication. Other things are, again, as time wears on, your medicines don't work quite as well. They're a little bit more unpredictable. And so people get really anxious and nervous about leaving the house. They have almost like a generalized anxiety disorder, a social phobia, because, oh my God, what if my meds start failing on me right in the middle of this activity or function? I'd rather not participate. And so sometimes treating Parkinson's a little better can help. Sometimes adding in some medications to treat this can, just to treat anxiety can help as well. And then there's also, I've heard a lot from patients and family, an obsession, almost, focusing on one thing, talking about it, having a hard time letting go. And this slide here, you saw it on the depression slide too. Serotonin is where the antidepressant category of medications really target their function. And we know that serotonin plays a huge role in mood, obsession, focus. And so these two systems, dopamine and serotonin, work hand in hand. So when one is not working well, dopamine, then serotonin can also get thrown off balance. Other behavioral disturbances that we often see is something called apathy. This is a lack of motivation, a lack of interest in things. I don't really care if my grandkids come over. I don't really care if I go do that activity that I always used to love to do. And there's a lot of different reasons why that may come up. As I mentioned, a lot of it has to do with Parkinson's disease and some of the unpredictability that comes with the medication and just how you're feeling on any given day. But sometimes it can also be a symptom of anxiety or depression, and it can also be a symptom of somebody who has memory problems. So we know that in more advanced dementias, a lot of our patients have a lack of interest or a disinterest in whatever they used to love to do. And then there's a group of disorders called impulse control disorder. Now, punding, this is shopping, gambling, hypersexuality, a variety of other things. These are stereotyped, repetitive behaviors that are often pleasureless. You just keep doing it because you feel this drive to do it, even though there's no reward in it for you. This tends to be a side effect of the dopamine agonist category of medications. That's the ropinirole, the pramipexole, the rotigotine. One would ask, why bother giving these meds? Well, they're actually excellent treatments for Parkinson's disease. So what we do is we kind of balance the risk and the reward. And we may try it, and if these symptoms come up, you talk to your doctor, and very often we have to cut down the dose or stop it. Dopamine dysregulation is a really rare occurrence, but can happen, and I've noticed it happens more in younger onset patients. And this is almost like an addictive behavior. You're using your medicine like a drug, where you take it and you take it and you take too much of it and you abuse it. And this can be really challenging. It has something to do with that anxiety that comes when you're wearing off, and people get so nervous and anxious about feeling that depression, anxiety, that they keep taking more and more and more. This is really hard to treat, and can be challenging for a lot of us. So if you do feel that way, it's important to talk to your physicians early rather than kind of let it get out of hand. So as I mentioned, there are more neurotransmitters than just dopamine, and I don't know how well this projects, but there's 8 chemicals on here. There's more than that. But here, I just wanted to highlight, dopamine is the pleasure chemical. Well, serotonin is the mood chemical. It makes us happy. Norepinephrine and adrenaline are your energy chemicals. And these all actually work really closely together, and one can off-balance the other. And all of these pathways kind of overlap, and so they're covering the same brain regions, and so you need more than just one to have good functioning and a good balance of your mood. And so I think when we printed the slides, I didn't realize it would cover up some of this, and I'm happy to share this particular slide with Mary Sue if anybody wants that. But basically, we're trying to find a balance, and sometimes we need more than one medication in order to achieve that balance. And so this is just another slide that tells overall roles and functions of these chemicals. This is obviously very broad brush overview, and it gets a little bit more sophisticated than that, but you can look at that in your own slide packet. And so finally, there's just to treat all of these neuropsychiatric symptoms, there's a lot of strategies. And the first strategy that I talk to about with all of my patients is we got to get you out there in the world. It is unbelievable how social interaction and just having purpose and activities can really make a big difference in how you feel, how your anxiety goes down, how your depression lifts. You know, a lot of times you're also approaching retirement or took an early retirement because of Parkinson's disease, and we underestimate the value of work. Work gives you something to do when you get up in the morning. It occupies a large chunk of your day, and it validates you. You feel like you've accomplished something. So all of a sudden, you've taken retirement. What are you going to do with all this time? And you're also not feeling great, right? So we have to come up with new activities to fill that time. I like to keep the same structure of a work schedule, get up at the same time, have 1 or 2 activities planned during the day. Maybe you volunteer, maybe you join an exercise class, but to get out there into the world and try to do things. We obviously want to optimize your medication therapy. If your Parkinson's is not well controlled, you're going to feel terrible. And so we want to, as best we can, keep that well treated. And then finally, a low dose of a mood medication can often go a long way. And I have a really short threshold to just say, let's try this. And a lot of times people come back and say, no, you gave me the lowest of low doses, and this was just what I needed to get a little bit more energy. So yes, it can seem like I'm taking so many pills, but that's what we do in order to keep you functioning and feeling well. So to switch topics, we're now going to talk about sleep disorders, and we're going to cover a few of these as best that I can. It doesn't hurt to talk a little bit about the sleep cycle, and I know most of the audience here are patients, you're not physicians, so I'm going to try to keep it simple. So there are 5 stages of sleep, and as you get deeper into sleep, a few things to pay attention to are that your body temperature goes down, your heart rate slows down, you get deeper and deeper and deeper into sleep, so it's harder to wake you up out of it. And then once you get crossover into the deepest stage of sleep, you go into something called REM. REM sleep is important because this is where you consolidate your memories. This is where you kind of problem solve almost. Problems in the day kind of get resolved in this area of sleep. This sleep, when we look at you with electrodes and look at your brain activity, it looks identical to being awake. The only difference between the two is that your muscles are all shut down, so that you're not supposed to be moving around except for some fluttering of your eyes. In Parkinson's and other conditions, this sleep, this shutdown of your body is not working well. And so a lot of people may have something called REM sleep behavior disorder, which is punching, kicking, fighting, thrashing in your sleep, which can be a problem. There's a few other things. So we'll talk about insomnias, which is going from wakefulness into sleep. This can be a problem for a lot of Parkinson's patients. We'll talk about REM sleep behavior disorder. I think it's important to talk about obstructive sleep apnea because this is just such a common condition. And then I was also asked to talk about vivid dreams, so I'll see if I can answer those questions. So to start with, insomnia is a trouble of one of 2 things: falling asleep or staying asleep. And this can be really challenging. Now, normal, healthy people can also experience insomnia. This is a common symptom of mood disorders like depression. There's a variety of other symptoms as well, such as restless legs, wearing off, and an irregular sleep-wake cycle. Impaired sleep can also happen because of wearing off. So wearing off, commonly your symptoms are well controlled during the day, but then we cut off all your medications at night. A lot of Parkinson's patients can handle this in the early parts of Parkinson's. However, as time marches on, you do need some medications in sleep, otherwise your tremors will come back, your stiffness, your slowness, your incoordination. And this all can affect your ability to sleep well. So REM sleep behavior disorder is when, and I put up this slide mainly just to show that we tend to have REM sleep more at the end of sleep. And so if you really have interrupted and disrupted sleep, you're not getting that good sleep quality that we want. So REM sleep behavior disorder is basically enacting your dreams. You're having this really vivid dream and your body didn't shut down. So you're punching, kicking, fighting, thrashing those demons, whatever you're fighting or running away from. And so this turns out to be a very common symptom, not only in Parkinson's and Parkinson's-like conditions, but other neurodegenerative disorders like Alzheimer's. Obstructive obstructive sleep apnea is just very common as people get older. And this can make people not sleep well and also almost have REM sleep-like disorders, behavior disorders. So if you're not sleeping well, it's not a bad idea to get a sleep study just to get a look at that a little closer. Vivid dreams. I searched the literature to try to understand why people have vivid dreams. And the best that I could sort out is that it's a complication of neuroactive medications. So one of my thoughts is that we have a lot of REM sleep at the end of the night, and then you wake up and that transition is not as smooth as it is for perhaps people without Parkinson's and not on those medications. So you just remember your dreams a lot more vividly. Daytime sleepiness is a result of many different things, but one of the most common causes is a terrible night's sleep. So we focus a lot on trying to get you to sleep better at night so that you're less exhausted during the day. If you're exhausted during the day and you sleep all day, you're not gonna sleep well at night either because you're not tired to go to sleep. And then it just throws off your entire sleep-wake cycle. So here are a few things. Fatigue is a really common symptom in Parkinson's disease, but also a common symptom in the general population. And so you are not alone with this. I think we're all expected to work harder, push longer, and we don't allow ourselves to rest enough. And then again, mood disorders can impact that as well. So how do I approach treatment of sleep disorders? Well, the first thing I do is try to have a good wind down sleep routine. Shut off all electronic devices, shut down your brain, have a relaxation pattern. Usually give yourself about an hour to wind down before you go to bed. Divorce your bed from being awake. So don't watch TV in bed, don't just hang out in bed all day. Get out of your bedroom, get out of your bed, and then you start associating, kind of like those Pavlov's dogs. When I go to my bed, I go to sleep. And it can sometimes really make a big difference. Obviously, during the daytime, I don't want you to be on sedating meds when I can avoid it. Sometimes we can't avoid it. And so then you're less likely to fall asleep during the day. And then these are just some tips and tricks that I use. Obviously, we want you to talk to your doctor before just buying melatonin and using it in higher doses. But I find that melatonin is a very effective medication for treating sleep in Parkinson's disease. Exercise is probably one of the best things you can do for Parkinson's, and it's a great combator for daytime sleepiness. It also makes you tired to sleep deeper at night. So just something that everyone should kind of make an effort to do. So just for the interest of time, I'm going to go a little faster so that we have time for questions. For dysautonomia, I wanted to explain what the autonomic nervous system is. This is the nervous system that controls everything that's involuntary in your body. So your heart rate, your blood pressure, your breathing, how your gut works, this is all controlled outside of your consciousness by this autonomic nervous system. And in Parkinson's, the autonomic nervous system goes out of balance as well, just like, unfortunately, some of the neurochemicals. And so on this slide, which you have, it just kind of separates where the sympathetic and the parasympathetic and what the roles of it are. And same organ system just makes them do different things. So I just wanted to show that. Now, neurogenic orthostatic hypotension is a really important thing that affects many people with Parkinson's disease. This is a sensation of feeling lightheaded or dizzy, sometimes feeling faint or fainting. And this is related to the lack of blood pressure response for when you're changing positions or doing various activities. The way we diagnose it is we observe a change in your blood pressure between two positions. Usually in the doctor's office we say sitting and standing, but it can also be from laying down and standing up. And we're seeing at least a change of 20 points in your systolic, or the top number of your blood pressure, or diastolic, the bottom number. Now, one caveat to having low blood pressure when you stand is for Parkinson's patients or patients who have dysautonomia, their blood pressure will actually increase quite substantially when you're laying down flat. So it can be quite challenging to treat. There's a lot of different strategies for this, and I put some conservative strategies. Obviously, talk to your doctors first. If you have heart disease or heart failure, some of these strategies are not meant for you. And so what I end up talking to my patients about and talking to their cardiologists and doctors about is we no longer want you to follow the general public guidelines or keep your blood pressure below 130 or 120, because when you stand up, your blood pressure may drop 30 or 40 points, and then you have a blood pressure of 60 when you're standing, and that's not enough blood to get up to your brain. So we'd rather allow you to have a little bit higher blood pressure so that when you fall, you're still falling within a range that keeps blood going to your brain. Turns out that too low of a blood pressure is actually more dangerous than too high. So if you have this problem, we start changing the rules on you a little bit. So why does this happen? Well, that autonomic nervous system, as I mentioned, controls everything, including how tightly your blood vessels constrict when you change positions. This is how we kind of combat gravity when we're changing positions in life. And so the signaling is disrupted, and sometimes instead of closing up, it'll actually expand. And that can be quite problematic because all of your blood is staying in your feet when your head is way up high. And so, again, there's no great treatment for this, but there are some medications that we can use. So the first thing is all Parkinson's medications can contribute to orthostatic hypotension. Sinemet can do it, carbidopa, levodopa, your dopamine agonists, and even some of our supplemental medications. So whenever possible, this is when I start to remove the less important medications and focus in on the most important, like levodopa. And then sometimes we have to reduce your antihypertensives. So when you go to your doctor's office and your blood pressure's in the 150s, nobody's asking you to stand up, and so they don't know what's happening when you stand up. So at least in our office, we check everybody's sitting and standing blood pressure, and that really that change really drives how we measure your blood pressure. So it's important to start pulling away some of those antihypertensives and talking to your cardiologist about that, starting that conversation. For the doctors in the room, these are some of the meds that I like to avoid. I prefer using the ACE and the ARBs because they have a less of an impact on your heart rate and your blood pressure and your constriction of your blood pressure. And when all else fails, we sometimes have to add medications to lift your blood pressure. And so these are some medications that we commonly use. For that supine hypertension, when your blood pressure skyrockets, captopril can be very effective for bedtime. And so if we're balancing it, sometimes you need 2-3 different medications to get control of it. And I know my Parkinson's patients hate taking pills, but this is how we keep things functioning and keeping you active. And so again, this is just, we're trying to find the right balance, right? If we just wanted to take away everything that was causing the side effect, we would get nowhere because your Parkinson's symptoms would be so terrible you wouldn't even be able to stand up or move. So we're always trying to find the right balance between too much medication and too little medication. Constipation. This is a very common problem in Parkinson's disease, and this, I found a better pictorial for this, so I did change the picture on you, but it's basically to show you that stool normally just passes, and in Parkinson's, everything is moving slow, including the muscles in your gut. So sometimes the stool kind of just sits there, and then it gets bigger, and then it gets bigger, and it's harder to pass, and then that autonomic nervous system is not coordinating that function as well as it could. So it's even harder to pass the stool, and this can really be a problem. Now, this is a common cause for having the delayed on. So, you know, if you find that you're waiting and waiting and waiting and your med just didn't kick in, you know, I talk to a lot of my patients and they say, oh, I have a bowel movement every 4 days if I'm lucky. Well, as soon as we start regulating the bowels, they say, oh, you know what? It's getting a little easier for my meds to kick in. So a really important thing to keep track of. These are some over-the-counter trips that I give most of my patients. This actually takes care of most of my patients' constipation, but if needed, we can also use prescription meds. You just have to talk to your doctor about that. So my usual strategy is to start with one, then add the other until you get regular. And once you're regular, you have to continue those medications. I was asked to talk about sweating and dry skin, and unfortunately, it is another symptom of dysautonomia. But it is something that is really hard to treat. I don't have a great strategy for it. Most people have drenching sweats all over their body, and there's no great medication to give you that doesn't have a side effect. Propranolol can sometimes work, especially if you wake up in the middle of the night with drenching sweat. Usually that might be related to your transition into REM sleep. If it's a really focal area, we can sometimes do something called botulinum toxin injections. For dry skin, just using thick lubricating creams. And I put on here, it sounds a little peculiar, but water is actually really drying to the skin. So you can actually take maybe a shower every other day, a full shower, and just do kind of a gentle cleanse on the important areas, and that can sometimes help treat that dry skin. So for the last few minutes, I'm going to talk about a potpourri of things that I couldn't really categorize into into a subheading. So speech changes I consider to be a motor symptom of Parkinson's disease. This is a loss of the caliber at which you speak, maybe a little stuttering or a little rapid trail off of your speech as you talk for a while. This is really hard to treat. Medications can sometimes help with this, and speech therapy is really effective. So loud therapy, the loud program for Parkinson's disease, is probably one of the best things that there is to treat the speech changes that come along with Parkinson's. Now, dysphagia is a difficulty with swallowing, perhaps even choking or coughing with foods or liquids. Another very difficult thing to treat. So again, Parkinson's meds can help a little bit sometimes, but usually isn't the mainstay of treatment for these. It's actually surrounded by speech therapy. So including loud therapy, we've done a lot of studies now that show just working on your speech and your vocalization can improve your muscle coordination for swallowing. There's other strategies. A lot of people nowadays, and even in Parkinson's, kind of tip their heads forward. Well, that throws your esophagus out of line. So just a simple chin tuck can actually straighten out your esophagus and make it easier to swallow. And sometimes we have to use diet modification. So you're not eating a big, tough piece of steak anymore, but rather cooking it down a little bit more, cutting it into smaller bites, and chewing longer. Sialorrhea is drooling. Now, the first question that I get a lot is, why am I making so much saliva? And it really isn't the production problem, but rather a consequence of not being able to swallow it fast enough. So again, Parkinson's is a condition of slowing down, so you're not swallowing what you're making. This is probably a normal production. And so there's a few strategies for reducing your sialorrhea. Glycopyrrolate is a pill that we can often use. In patients that are older with memory problems, I get a little bit hesitant just because it can have some side effects and make that a little worse. Atropine drops in the mouth. This is actually an eye dropper that I find works really well, and it keeps it just in the mouth without too many side effects. You'll have to talk to your doctor about the off-label use of it. And then finally, botulinum toxin injections can be very effective. And I put this slide up here because I wanted to point out that there are two glands that are involved in, well, three technically, but two glands that we can easily inject for sialorrhea. And sometimes people start with just one gland, the parotid, which is the most common in the cheek, and that isn't enough. And it doesn't hurt to ask your doctor to add in the submandibular gland. Out of practice, I've just always done both and had pretty effective treatment. A lot of my patients have been offered scopolamine patches, or patches to put behind the ear to help with their drooling. And the few that have gotten it have come back to me and said, wow, I am hallucinating, or their family member says, they all of a sudden started hallucinating. Though this is a great anti-drooling drug, it's not a great one in Parkinson's because it has a lot of unintended consequences. I was also asked to talk about the loss of sense of smell, which is called anosmia. And along with that comes a less descript condition called dysgeusia, which is a change in your taste. Some people actually find this really distressing, the change in taste. Most people don't notice it. I don't hear that complaint a lot. Anosmia, the loss of sense of smell, occurs in more than 90% of Parkinson's patients, so very common in this condition, and often one of the earliest symptoms of Parkinson's disease, well before the tremors and the stiffness and slowness come up. This can be a contributor to weight loss, and treatment, I put high-calorie diet. I meant to say more high-fat diet, more flavorful diet, more sugar. It's just something that stimulates your palate because the typical sensations are a little bit disguised. So that kind of leads into early satiety and weight loss, another very common symptom of Parkinson's disease. So as I mentioned, the gut slows down and it doesn't work as well. Well, this leads to something called gastroparesis, where everything in your stomach just kind of sits there. You're constipated, so things aren't moving forward, so they back up into the stomach, and then you're not hungry, so you don't want to eat. You feel bloated, you just don't feel great. Your meds make you nauseous. And so this is just a common symptom, and there isn't a great treatment for it. Usually I recommend high-calorie supplements like shakes and Sure. There's also, we've learned that there's changes in your hormone secretions. There's hormones that tell you when to be hungry and tell you when you're full, and those are out of balance as well. Basically, small meals, high calorie, and there's no restriction. I tell people to eat whatever they want as long as they're also eating some nutrition. So you can't have chocolate cake for breakfast, lunch, and dinner. You have to have, something nutritious in between. But sure, have 3 slices of cake if that helps you get calories in. And then vision changes is another thing that really can be quite challenging for my Parkinson's patients. When we look at things, our eyes have to kind of move in sync. And when we're trying to focus, your 2 eyes need to come together to focus a little bit better. And that function, what we call convergence, is what is affected in Parkinson's and can be really distressing for some of my patients. Often I hear, my vision's blurred, I just can't see right, I have a hard time focusing on moving objects. This also, we believe, eye movements are a function of the basal ganglia and an area that is probably degenerating. And the treatment is actually quite challenging. If you have a fixed focus problem, which an ophthalmologist can evaluate for, prism lenses can help. You can also, a few other strategies that I found, you can avoid bifocal lenses. Those are really hard to look through for Parkinson's. And then I had a patient recently tell me that when she got her cataracts, she had 1 eye for distance vision and 1 eye for close vision. And that turns out to be really distressing because your eyes already have a hard time shifting and balancing. And so I would recommend against that if your cataract surgeon ever offers it to you. The last thing I'm going to talk about is there is an increased risk for melanoma skin cancer in Parkinson's disease. They say about a 5-fold increase compared to the regular population. So it's something just to be aware of. It's not necessarily a non-motor symptom, but something to keep in your mind and to talk to your doctors about so that you get a yearly screening either with your primary care doctor or a dermatologist. Now, one would ask, a lot of the medications say you may develop melanoma. This is not we believe this is not a side effect of the medication, but rather, in the beginning, or I think in Kara, your talk, the substantia nigra, where the dopamine-producing cells lie, they're full of melanin, the same thing that is abnormal in malignant melanomas. And the brain and those melanocytes actually are derived from the same precursor cells. So we think it probably has something to do with the genetic makeup and something that may put Parkinson's patients at risk. So with that, any questions? And we can field questions for Dr. Wynant as well.
Hi. I had a question about pain. I've developed severe pain on my right side, and I wanted to go to orthopedic doctor to have him check my knees and see if there's anything wrong. Do you think that's silly? Do you think it's just a symptom of the Parkinson's, or could I also have a knee problem?
Well, here's the thing about having Parkinson's. You're still a person. And so, yeah, you can have arthritis. So I think it's important to always make sure that there isn't something else going on with it. But what I tend to advise my patients is, especially if you have stiffness around the muscle rather than in the joint, it may have something more to do with Parkinson's, and something like physical therapy can really help both arthritic knee pain as well as Parkinson's stiffness. So it doesn't hurt to do a little bit of physical therapy before you jump onto the operating table. But yeah, I think it's perfectly reasonable to go see an orthopedist about that.
Is there any trouble taking naps?
No, I actually recommend it. Or are you saying, do people have trouble taking naps?
No. Sometimes I'll get up and take my meds and then go back to sleep for half an hour, and the chemicals kick in.
Yeah, it's not a bad idea. There's a couple reasons why people take naps right after their medications. One is because Cinemet and some of the other medications can really make you drowsy. And the other is you're wearing off on your Parkinson's, so it's just harder to move and makes you more tired and sleepy and down. So if it's not really throwing off your day-to-day activities, it's not a bad idea to take a nap. Now, we don't want you to spend all day sleeping either, so it's a fine balance. Dr. Patel?
In treating constipation, do you recommend a position change, body position change sometimes?
How do you mean?
Well, there's the squatty potty.
Yes, actually that does help. So it just kind of promotes gravity and pulling everything down and out. So yeah, it's not bad. Whenever you can, I'm the first proponent of don't use medications to treat everything, but use them if we're not making way in other strategies. So drinking enough water is probably the hardest thing my Parkinson's patients say, because, oh, well, then I have to go to the bathroom, and it's just so much work to drink that much water. But staying hydrated is so important, and then things like position help as well.
My Parkinson's affects mainly my left side, and so I'm over here. Am I the one
Looking.
talking? Okay.
Okay.
And my muscles are affected on my left side. What I wonder, does it also affect the heart muscle?
To my knowledge, I don't think it does, because for the most part, Parkinson's patients are really healthy, and we don't see a lot of congestive heart failure or heart attacks or other things. That being said, I don't know 100% if there is a subtle change. Yeah. Dr. Patel? Probiotics don't hurt. I'm not opposed to them. Yeah. It's my it's my favorite question. So we are in a legal state. So the question was, what about medical marijuana? So in the state of Michigan, medical marijuana is legal. Each physician has their own opinion on it, and what I can tell you is there is no evidence, scientific evidence, when I look at literature and we do studies that support medical marijuana having a meaningful impact on Parkinson's disease and how it works. So I don't think you're missing out on it. However, there are some symptoms where we know medical marijuana helps, such as nausea, appetite stimulation, anxiety. So what I generally recommend is talk to your physician and make sure that they're on board with you trying it. So carbidopa is actually the chemical that goes along with levodopa. And carbidopa, for all intents and purposes, is the anti-nausea component to levodopa. Levodopa is the precursor for dopamine. It's basically replacing dopamine in your brain. Serotonin is a different chemical that is influenced by the levels of dopamine in your brain. So just by taking some levodopa, you can artificially almost elevate your serotonin levels a little bit. But there are two different compounds that communicate in the brain. Well, if you have symptoms of depression or anxiety or low mood, your doctor will kind of recognize that, and that's a symptom of low serotonin. very simplistically put.
Dr. Wyatt referenced a PET scan. Can you explain a PET scan versus a SPECT scan in determining or looking at atypical?
Should I have her come up and answer that question? I think that's probably.
Before you leave, may I ask a question of you?
Oh, sure. I'll still stay up here. If you want to just come up here.
So a PET scan is also a nuclear medicine scan. So patients are injected with a radio tracer that binds a certain glucose or other molecule, goes to the brain and looks for different activities, okay? So we're looking for dopamine activity specifically with a SPECT scan and a PET scan to look at Parkinson's disease. So it's a little bit better picture than the SPECT scan. It also looks at, you can have it do different tracers, so you can look at different areas of the brain. So there is some evidence that it's better at predicting what is a dopamine loss due to Parkinson's disease versus one of those atypical Parkinsonisms or mimics of Parkinson's disease. But that's all about patterns. These are not available commercially. It's something that are usually only available at research institutions, and you really want to go to a place that knows how to interpret them. So it's one of those where the caveat was, it's great, it may be coming in the future. Right now, it's not something we use clinically.
Our last question.
My question is about taking the medications for Parkinson's. I take many other medications, and I take medications 4 times a day. But you're saying the Parkinson's medication should be taken before 30 minutes before meals. So I forgot it. I left it at home. Or remember it, and it's 40 minutes later. Do I skip it? How do I get back on schedule? And unfortunately, you know, if I sleep late, then everything's pushed towards the evening when you say, I don't need the treatment for it as much as I do earlier in the day. Any help?
I guess I'll answer this one. So every physician has a little different philosophy on food and levodopa, but the general message is that we want you to take your levodopa. So if you forget to take it, or, oh my gosh, I got hungry and I want a snack, you still need to take your levodopa. It's not to say don't take the levodopa. It's just kind of best practices. So if you are late, take it when you remember it, okay? So if you're 30 minutes late or an hour late, take it when you remember it. And if you're set at about 4 to 5 hours apart, that's fine if you just take the next dose on schedule. If you're a little tighter than that, what's more important to us is the hours in between each dose. Your levodopa lasts, and it's individualized, so your levodopa on average lasts about 4 hours. But for somebody else, it may be 5 or 6, and for somebody else, it might be 2. And so whatever that schedule of benefit is for you, we want you to be within that window. So if you're 30 minutes late, just go ahead and take it on time for the next dose. If you're 2 hours late, you might shift it so that you take it 4 hours after you took that kind of dose when you remembered it. Does that make sense? Yeah, and it's imperfect, and we get it. And I know we tell you the best practices, but we're very forgiving if you don't follow our rules exactly.
Thank you very much, Dr. Patel. That was an excellent summary. We really appreciate it. And if I might address that last question, just set the timer on your phone to 8, noon, 4, and 8 to ring every day, so that'll solve the problem.